Today's show comes to you courtesy of the target cell's accidental artistry. When viewed under the microscope, these red blood cells present themselves as miniature works of abstract art, resembling a perfectly formed bullseye or a tiny, exquisite sombrero. This isn't a deficiency, it's a structural peculiarity born from various, often benign, non-megaloblastic conditions. They simply prefer to stand out from the crowd, showcasing their unique membrane configuration as a badge of distinction in the vast river of the bloodstream.
Welcome back to The Deep Dive, the podcast where we put the lab results under the microscope to understand the full patient story.
Great to be back. Last time we tackled the textbook macrocytic anemias, the megaloblastic anemias. We unpacked the story of impaired DNA synthesis, B12 and folate deficiency, and those classic hypersegmented neutrophils. Today, we're moving on to a trickier scenario. We're staying in the world of large red cells, but we're exploring what happens when the cause isn't a vitamin deficiency. We're talking about non-megaloblastic macrocytic anemia.
It's the perfect follow-up. This is the scenario that plays out all the time. The analyzer flags a high MCV, say 105 femtoliters. Based on our last discussion, the first spot is often B12/folate, but then the chemistry results come back and the vitamin levels are completely normal. Now what? That's where the real investigation begins, and that's where the MLS becomes absolutely critical.
Exactly. Because you've already ruled out the most common culprit, you have to become a true detective. Our goal today is to arm you for that investigation. We're going to systematically unpack the major causes of non-megaloblastic macrocytosis. We'll connect the pathophysiology, the why of conditions like liver disease, alcoholism, hypothyroidism, and MDS, directly to what we see on the CBC printout and on the peripheral blood smear.
This is all about pattern recognition. It's about looking at that high MCV not as a single data point, but as the first clue in a much larger puzzle. We'll discuss why the red cells are big, what other cell lines might be telling you, and which reflex tests are the key to cracking the case. So let's start at the beginning. Before we dive into the causes, what are the defining features that tell us we're not looking at a megaloblastic process?
That is the foundational question, and it builds directly on our last episode. The term megaloblastic refers to a very specific pathology, impaired DNA synthesis, which causes a nucleocytoplasmic asynchrony during cell development in the bone marrow. This leads to very characteristic findings. The number one thing you look for on the smear to rule in a megaloblastic process is the hypersegmented neutrophil.
The classic six-lobed or more neutrophil. If you see those, you're almost certainly in megaloblastic territory. The other key feature is that the macrocytes in megaloblastic anemia are typically oval-shaped. We call them macroovulocytes. So, by definition, in non-megaloblastic macrocytic anemia, you are not going to see true, consistent hypersegmented neutrophils. And the macrocytes tend to be large and round, not distinctly oval.
Perfect distinction. So the CBC shows a high MCV, but the smear lacks those two key features. We've ruled out the usual suspects. Now where do we look? Let's start with arguably the most common cause of non-megaloblastic macrocytosis you'll encounter.
That would have to be liver disease, often hand-in-hand with alcoholism. This is such a classic picture, and the pathophysiology is fascinating. It has nothing to do with DNA synthesis and everything to do with the red cell membrane.
Right. The liver is the master regulator of the body's lipid and cholesterol metabolism. When the liver's diseased, that regulation goes haywire. You get an imbalance of serum lipids, specifically an increase in cholesterol and phospholipids. These excess lipids get passively loaded onto the membrane of circulating red blood cells.
Think of it like this. You're adding more material to the surface of the red cell. This increases the red cell's surface area. The automated analyzer calculates the MCV based on the cell's volume as it passes through the aperture. And this increase in surface area results in a larger, floppier cell that the instrument measures as having a higher volume. So the MCV goes up. But notice the amount of hemoglobin inside hasn't changed. This is why the MCHC is typically normal. You've made the bag bigger, but you haven't put more stuff inside.
And what does this look like on the peripheral blood smear?
This is where the MLS adds so much value. You'll see these uniformly round macrocytes. They're just big, round red cells. And because of that increased surface area to volume ratio, you'll very often see a proliferation of target cells, or codocytes. The membrane is so redundant that the hemoglobin pools in the center, creating that classic bullseye appearance. A field of round macrocytes and prominent target cells should immediately make you think of liver disease.
If the liver disease is really severe, especially in alcoholic cirrhosis, this lipid dysregulation can become extreme. This is where you get the most dramatic RBC shape abnormality associated with liver disease, the acanthocyte or spur cell. These are cells with irregular, spiky projections of varying length and width. This happens when there's a massive, disproportionate loading of cholesterol onto the membrane, which deforms it permanently. Finding acanthocytes in this context is a very poor prognostic sign.
So the MLS sees round macrocytes, target cells, maybe some acanthocytes. The MCV is high, say 102 to 110 femtoliters, and the MCHC is normal. What's the next logical step in the lab to confirm this suspicion?
You look at the chemistry results for the liver function tests, or LFTs. You'd expect to see elevations in AST and ALT. In alcoholic liver disease specifically, you classically see an AST to ALT ratio greater than 2. You'll also see a significant elevation in GGT, the gamma-glutamyl transferase, which is quite sensitive for alcohol-induced liver damage. Seeing that combination of hematology and chemistry findings creates a very strong, cohesive diagnostic picture.
A perfect example of integrating data across lab departments. Now, let's move to another common reason for a high MCV that can sometimes be misinterpreted. It's not a true change in the mature red cells, but rather a reflection of the bone marrow's response. I'm talking about reticulocytosis.
Yes, the great MCV imposter. This is a purely physiological finding. We have to remember that reticulocytes, the immediate precursors to mature red blood cells, are inherently larger than mature RBCs. They haven't fully condensed and are still shedding their remnant RNA. A normal reticulocyte is about 20% larger than a mature erythrocyte.
So if a patient's bone marrow is cranking out a huge number of reticulocytes, for instance, to compensate for acute blood loss or a hemolytic process, that flood of large young cells into the circulation is going to drag the average red cell volume up. The instrument sees all these big cells and reports a high MCV.
The key here is that the high MCV is a secondary finding, an artifact of a powerful bone marrow response to anemia. The primary pathology is whatever's causing the hemolysis or blood loss.
When viewed under the microscope, these red blood cells present themselves as miniature works of abstract art,
You'll see prominent
resembling a perfectly
polychromasia.
formed
These are the
bullseye
large,
or a
grayish-blue
tiny,
red cells
exquisite
that represent the
sombrero.
reticulocytes
This
when
isn't a
stained with white
deficiency.
schemza.
It's a
Visually
structural
confirming
peculiarity
significant
born from
polychromasia
various,
is step
often
1.
benign,
Step 2
nonmegaloblastic
is ordering the
conditions.
definitive test,
They
a
simply prefer to
reticulocyte
stand out from the crowd,
Exactly.
showcasing their
If the
unique
cause of the
membrane
macrocytosis is a
configuration as a
reticulocyte
badge of
response,
distinction
then the
in the
absolute
vast
reticulocyte
river of
count
the
will be
bloodstream.
high.
Welcome
and the
back to the
reticulocyte
Deep
production
Dive, the
index,
podcast
or
where we put the
RPI,
lab
will be
results
greater
under
than
the
2,
microscope
indicating
to understand
an
the
appropriate
full
and
patient
robust
story.
marrow
It's great
response
to be
to
back.
anemia.
Last time
This
we
is in
tackled the
contrast to other
textbook
causes of
macrocytic
macrocytosis,
anemias,
like
the
MDS or liver
megaloblastic
disease,
anemias.
where the
We
marrow
unpacked the
production is
story of
often
impaired
ineffective
DNA synthesis,
and the ret count is
B12 and
inappropriately
folate
low.
deficiency,
And
and
another
those
clue on the
classic
CBC could be the
hypersegmented
RDW.
neutrophils.
Because
Today
you
we're
have a
moving
mixed
on to a
population
trickier
of
scenario.
very large
We're staying in the
reticulocytes
world of
and
large red
normal-sized mature
cells,
red cells,
but we're
you have
exploring
a
what
high
happens
degree
when
of
the
size
cause
variation
isn't a
or
vitamin deficiency.
anisocytosis. This
We're
will
talking
result
about
in an increased
non-megaloblastic
RDW, so a high
macrocytic
MCV
anemia.
with
Unlike the
significant
membrane issue
polychromasia on
in
the
liver
smear
disease,
and a
this
high
is an
RDW
intrinsic
should immediately
maturation
trigger the
defect.
thought,
The
let's check the
erythroid
ret count.
precursors in the bone marrow
And if that
are
ret count is
abnormal.
high, the
They have
investigation then
developmental
pivots to
problems
finding
that
the
can
cause
lead
of the
to them being released
reticulocytosis.
as large,
You'd start
dysfunctional
looking
cells.
for evidence of hemolysis.
The important thing to
high
remember
LDH,
is that this isn't
high
just an
indirect bilirubin,
erythroid problem.
and low haptoglobin.
MDS is a
The
stem cell
macrocytosis
disorder,
was just the
so you need to
signpost
be looking
pointing
for
you in
signs
that
of
direction.
dysplasia in
All
all
right,
cell lines.
we've covered two major players, liver disease and reticulocytosis. Let's shift gears to a more complex and, frankly, more ominous cause of non-megaloblastic macrocytosis, myelodysplastic syndromes, or MDS.
And that is the
This is where
absolute
the
key
MLS
to
is
suspecting
truly a
MDS from the
frontline
peripheral smear.
diagnostician.
A high
MDS is a
MCV in
group of
isolation
clonal
could be
hematopoietic
anything,
stem cell
but a high
disorders.
MCV
In
accompanied
simple
by
terms,
other
the
bizarre
factory is
findings
broken.
is a
A
huge
malignant
red
clone
flag
in the
for
bone marrow
MDS.
is producing
Let's
blood
break
cells,
down what an
but they are
MLS should be
defective
hunting
or
for.
dysplastic, and many die before they even leave the marrow, leading to peripheral cytopenias. Macrocytosis is a hallmark finding in many types of MDS.
What's the pathophysiology here? Why are the cells large?
Unlike the membrane issue in liver disease, this is an intrinsic maturation defect. The erythroid precursors in the bone marrow are abnormal. They have developmental problems that can lead to them being released as large, dysfunctional cells. The important thing to remember is that this isn't just an erythroid problem. MDS is a stem cell disorder, so you need to be looking for signs of dysplasia in all cell lines.
And that is the absolute key to suspecting MDS from the peripheral smear. A high MCV in isolation could be anything, but a high MCV accompanied by other bizarre findings is a huge red flag for MDS. Let's break down what an MLS should be hunting for.
First, look at the other cell lines on the CBC. Is there also a neutropenia, a thrombocytopenia? MDS often presents with bi- or pancytopenia, a macrocytic anemia in an older adult with a low neutrophil and platelet count is highly suspicious for MDS. Then you go to the smear. In the neutrophils, you look for the classic dysplastic feature, hyposegmentation. This is the pseudo-Pelger-Hewitt anomaly, where you see neutrophils with only one or two lobes, a pince-nez or dumbbell shape. You also look for hypogranulation, neutrophils that look pale and lack their normal secondary granules.
Then you look at the platelets. Are they normal? Are you seeing giant platelets, or maybe hypogranular ghost platelets? Dysmegakaryopaesis is another pillar of the diagnosis. And finally, you circle back to the red cells. You see the macrocytosis, but you might also see other dyserythropoietic features like basophilic stippling or circulating nucleated red blood cells that are inappropriate for the degree of anemia.
Putting it all together, an older patient with a macrocytic anemia, maybe some other cytopenias, and a smear showing hypolobated neutrophils. Giant platelets, and funky-looking red cells. That is a picture that screams, consider MDS. Your comment on the smear review is what prompts the clinician to consider the next definitive diagnostic step, which is a bone marrow aspirate and biopsy with cytogenetics.
It's a perfect illustration of our role. We aren't diagnosing MDS from the smear, but we are providing the essential evidence to justify a bone marrow exam. Our observations are the critical link in the diagnostic chain.
There are a couple of other less common but still important causes worth mentioning. What about hypothyroidism?
Hypothyroidism can certainly cause a mild non-megaloblastic macrocytosis. The mechanism isn't perfectly understood, but is thought to be related to the effects of thyroid hormone on erythropoietin stimulation and red cell membrane lipids. It's really a diagnosis made by exclusion, when other causes are ruled out and confirmed by a thyroid panel showing a high TSH and a low free T4.
A good one to keep in the back of your mind. And one last one, which is more of a lab artifact, but one every MLS needs to know how to troubleshoot. What about cold agglutinin disease?
The classic spurious macrocytosis. This is a great bench-level problem. In cold agglutinin disease, you have an IgM antibody that causes red blood cells to clump together at temperatures below core body temperature. When this blood sample cools to room temp on its way to the lab, the RBCs form massive clumps.
And the automated hematology analyzer, with its impedance or laser-based technology, can't distinguish a clump of 10 red cells from one single giant cell. It sees this huge aggregate pass through the aperture and calls it a single cell with an MCV of like 140 femtoliters. Simultaneously, since it's undercounting the total number of individual red cells, the RBC count will be falsely low, and the MCHC will be falsely impossibly high, often over 40 grams per deciliter.
That pattern is the dead giveaway. A sky-high MCV, a rock-bottom RBC count, and a critically high MCHC. When you see that combination, your first thought shouldn't be pathology, it should be pre-analytical artifact.
The fix is simple. Warm the sample in a 37-degree heat block or water bath for 15 to 30 minutes to dissociate the agglutinins and immediately rerun it while it's still warm. If the parameters normalize, you've diagnosed the cold agglutinin and avoided reporting dangerously incorrect results.
A fantastic point and a critical piece of practical lab knowledge. So let's try to summarize the MLS's diagnostic thought process. A sample comes in with an MCV greater than 100 femtoliters.
Step 1. Look at the smear. Are there hypersegmented neutrophils and oval macrocytes? If yes, you're in megaloblastic land, which we covered last time. If no, proceed down the non-megaloblastic pathway.
Step 2. Still on the smear, what's the morphology? Are the macrocytes round and accompanied by target cells? Think liver disease. Is there prominent polychromasia? Think reticulocysis. Are there dysplastic changes in multiple cell lines? Think MDS.
Step 3. Look at the other CBC data. Is the MCHC impossibly high? Think cold agglutinin. Is the RDW high? That points to a mixed population seen in reticulocysis or MDS. Are other cell lines low? Again, points to MDS.
Step 4. Integrate with reflex testing. A RET count will confirm or rule out a regenerative response. Liver function tests and a thyroid panel will pinpoint those specific organ-based causes. Normal B12 and folate levels confirm you're on the right non-megaloblastic track.
It's a beautiful cascade of logic that starts with a single number, the MCV, and blossoms into a full investigation that spans the entire lab. It shows how we're not just button pushers. We are investigative professionals who interpret complex data sets to help clinicians.
Well said. The non-megaloblastic macrocytic anemias are a perfect example of this. There's no single simple answer. The answer lies in the patterns, the context, and the keen eye of the medical laboratory scientist at the bench.
A great place to wrap up. We've journeyed from the lipid-laden membranes and liver disease to the defective factory of MDS. Hopefully this gives our listeners a solid framework for the next time that high MCV with normal B12 lands on their desk.
Absolutely. Thanks for listening.